Hello and welcome. Today we're diving into a condition that can significantly impact a woman's reproductive health: Asherman syndrome. This condition, also known as intrauterine adhesions, can lead to a range of issues, from infertility to recurrent miscarriages. Join us as we explore its causes, symptoms, diagnosis, and treatment options. So, what exactly causes Asherman syndrome? In the vast majority of cases, it's linked to surgical procedures performed on the uterus. The most common culprit is dilation and curettage, or D&C, often performed after a miscarriage, childbirth, or elective abortion. Other potential causes, though less frequent, include uterine infections such as endometritis, especially after a cesarean section. Rarely, Asherman syndrome can arise from other uterine surgeries like myomectomy or from radiation therapy to the pelvic area. Let's talk about the pathophysiology, or, in simpler terms, how Asherman syndrome develops within the uterus. The endometrium, the inner lining of the uterus, is highly sensitive, particularly after pregnancy. Trauma to this lining, often during a D&C, can damage the basal layer. This damage can trigger the formation of scar tissue, or adhesions, within the uterine cavity. These adhesions can vary in size and severity, ranging from thin, filmy strands to thick, dense bands that can partially or completely obliterate the uterine cavity. The presence of these adhesions disrupts the normal endometrial function, affecting menstruation, implantation of a fertilized egg, and the overall ability to carry a pregnancy to term. While precise epidemiological data for Asherman syndrome is limited, it's estimated to occur in around 1.5% of women undergoing hysteroscopy, a procedure used to visualize the inside of the uterus. However, the prevalence is much higher in women who've undergone multiple D&C procedures, particularly after a miscarriage or postpartum hemorrhage. This highlights the importance of careful surgical technique and the consideration of alternative management options when appropriate. The signs and symptoms of Asherman syndrome can vary depending on the extent and severity of the adhesions. Some women may experience changes in their menstrual cycle, most commonly a decrease in menstrual flow or even anorrhea, the complete absence of menstruation. Others may experience cyclical pelvic pain, especially around the time they would normally be menstruating. Infertility and recurrent pregnancy loss are also common presentations. It's important to note that some women with mild adhesions may not experience any noticeable symptoms, making diagnosis challenging. Diagnosing Asherman syndrome typically involves a combination of clinical history, physical examination, and imaging studies. A detailed history, including any previous uterine surgeries or infections, is crucial. A pelvic exam may be performed, although it's often not diagnostic on its own. The gold standard for diagnosing Asherman syndrome is hysteroscopy, which allows direct visualization of the uterine cavity and the extent and location of any adhesions. Other diagnostic tools include hysterosalpingography, or HG, an X-ray procedure using dye to outline the uterus and fallopian tubes, and saline infusion sonography, or SES, an ultrasound technique that uses saline to distend the uterine cavity. Asherman syndrome is often classified based on the severity of the adhesions and the extent of uterine cavity obliteration. One commonly used classification system categorizes adhesions as mild, moderate, or severe, depending on the amount of uterine cavity involved and the presence of adhesions in the fallopian tube openings. Another system focuses on the type of adhesions, differentiating between filmy, dense, and confluent adhesions. These classifications help guide treatment decisions and predict prognosis. The primary goal of treatment for Asherman syndrome is to remove the adhesions and restore the normal shape and function of the uterine cavity. The most common treatment method is hysteroscopic adhesiolysis, a surgical procedure performed through the hysteroscope. During this procedure, specialized instruments are used to carefully cut or lyse the adhesions. Following adhesiolysis, measures are taken to prevent the recurrence of adhesions. This often involves the placement of an intrauterine device, or IUD, and/or the administration of estrogen therapy to promote endometrial growth. Follow-up hysteroscopy may be necessary to ensure complete removal of adhesions and assess endometrial healing. Management also addresses underlying causes like infections. While it's not always possible to completely prevent Asherman syndrome, there are steps that can be taken to minimize the risk. The most important is to avoid unnecessary D&C procedures, especially after a miscarriage. Medical management of miscarriage or the use of vacuum aspiration instead of sharp curettage may reduce the risk of adhesion formation. When a D&C is necessary, careful surgical technique is essential to minimize trauma to the endometrium. Prompt treatment of uterine infections can also help prevent adhesion formation. The prognosis for women with Asherman syndrome varies depending on the severity of the condition and the effectiveness of treatment. With successful adhesiolysis, many women are able to conceive and carry a pregnancy to term. However, the risk of recurrent adhesions, infertility, and pregnancy complications, such as preterm labor and placental abnormalities, remains. Recent research is focused on developing new techniques to prevent adhesion formation and improve endometrial regeneration. These include the use of stem cell therapy, growth factors, and barrier gels to promote healing and prevent scarring. While these approaches are still in the early stages of development, they hold promise for improving outcomes for women with Asherman syndrome.